On this episode of ADE Spotlight Podcast, I had the opportunity to speak with somebody that I've known for a while and somebody whose work I greatly admire. Allan Barger is a research analyst for Prevention Research Institute out of Kentucky, and I asked him to join us today to talk about marijuana, both medical marijuana and recreational marijuana. It's my hope that Allan will be able to help us shed some light on the pros and cons of these issues, shed some light on what the current research tells us about medical marijuana, and maybe talk about some of the misconceptions that exist in the general public and also some of the barriers to researching effective uses of marijuana in the medical field. Allan has a wealth of information. I've enjoyed listening to him over the years, and I believe that you'll enjoy this conversation as well. Allan, thank you so much for joining us. I've been looking forward to this conversation for quite a while. I think
likewise, Jim.
I'm hoping what we can do today is just get an unbiased view of both medical marijuana and recreational marijuana, and provide the listeners here with some clarity in terms of what we're talking about when we talk about the differences between medical marijuana and recreational marijuana and some of these larger questions. But first, why don't, if you could, just go ahead and tell us a little bit about yourself, about your interest in this topic and your experience as you've researched and done the number of presentations that you've done.
Okay, sure. Well, first of all, thanks for this opportunity. I think it's great. I work for Prevention Research Institute, and we do programs for people who are harmfully involved with alcohol and drugs. And there are some people, marijuana is that drug. So a number of years ago, actually, I was asked by the administration at PRI to really dig into the marijuana literature. So my title at PRI is that I'm a research analyst. And I want to be clear about what that means, which is that I am tasked with reading across the research literature across multiple fields. And the reason I think that's important to mention up front is because anytime you're looking at an issue, fields are sort of siloed. So psychologists look at psychological stuff, sociologists look at sociological stuff, doctors and biologists look at the biology. And we read across all of that literature and then try and pull the pieces together to get a fuller picture of what's going on with issues. And marijuana is one of those issues that cuts across all of those fields. There's recreational use, there's problematic use, and then there's medical use. And so I think just sort of pulling all those pieces apart is important, but being able to read broadly across the different fields also contributes to having a fuller picture. It's like putting a puzzle together until the pieces sort of give you a larger picture than any one piece will do. And I got started in this back in the mid-90s. Started reading in the marijuana research literature. This was shortly after the discovery of the human cannabinoid system. And so there was just an explosion of research really looking at how does marijuana and its various components act in our bodies now that we know that we have this natural cannabinoid system in our own bodies. And so it was really a fortunate time to really start reading in this and catching up with things. And then, in our culture, the issue of marijuana has now become, of course, a huge issue. And so we it's also a good time to be looking at the range of issues around marijuana, from medical to recreational and so forth. So that's sort of how I got into this. And I have to say, it's been a fascinating ride so far.
I like the visual image I had when you talked about silos. I want to come back to that because that's one of the key reasons I wanted to talk to you. But before we do that, just talk a little bit more about Prevention Research Institute. For the listeners here, we
Sure.
at ADE, we have worked with Prevention Research Institute for quite a number of years. I think very highly of the folks in your organization, as you know. We did a prior conversation, a podcast with Ray a number of months ago, which was fascinating, and he talked about how PRI, Prevention Research Institute, came to be and all of that. And we had a very good conversation. But maybe just tell the folks just a little bit about what your organization does.
Sure. So we're a nonprofit organization. We're located headquartered in Lexington, Kentucky. We develop two programs: the Prime for Life program, which is designed for professionals to use working with people who are having alcohol or drug problems, but may or may not need treatment. For instance, with impaired driving offenders. People who go out and get arrested driving under the influence of alcohol or drugs. Not all of them are chemically dependent. Not all of them are going to need treatment, but they obviously have some issues, and it's an opportunity to sit down with them and really look at what they're doing in their lives and where they're going and whether or not that's where they want to be going. So it's a gentle, sort of non-judgmental approach of, let's look at things, and then in the end you decide what you want to do. So that's Prime for Life. Then we also developed the Prime Solutions program. Prime Solutions is designed for use by professionals in treatment programs, and that one builds upon what we do in Prime for Life, but they are each standalone programs. But Prime Solutions allows counselors to sort of implement evidence-based practices like cognitive behavioral therapy and motivational interviewing approaches and so forth, just by implementing the program the way it's designed. So Prime for Life is actually an evidence-based program. It's listed in SAMHSA's National Registry of Evidence-Based Programs and Practices. And Prime Solutions doesn't have that level of research yet, but to call it evidence-based because it requires a history of research on it, and Prime Solutions is relatively new. But it is an evidence-derived program, which means it's built upon and built using evidence-based practices. So what we do is we develop those programs, and then we train other professionals to implement them, because evidence-based programs need an evidence-based implementation. They have to be done with fidelity. So our work is to just try and build really good tools for people who are in the prevention, intervention, or treatment fields to use, and then train them in the effective use of them. And in doing that, we've really tried to look not only at the research that would give us accurate information, but also the psychological research on how people change and what assists people in making behavior change that will be beneficial to them and to their families and communities and so forth. So that's basically our work, is to develop those tools and train other professionals in using them. And my job at PRI then is to, as I said, read broadly across several different subjects of research. The marijuana I've mentioned, other drugs as well, the neurobiology of addiction and those types of things, to keep up with what's happening in the research in those areas, and then use that, infuse that research-based information into our programs, and then also work with professionals to make sure that they're up to speed on the sort of the latest that we know from the research literature, both in what we're telling clients and also in how we're interacting with clients. So we've always sort of said tongue-in-cheek at Prevention Research Institute that research is our middle name, but it really is very important to what we do.
Well, you are just one of a great team of people at PRI. As you know, I think the world of the folks there and the work that they do.
I do have a great team. There's no question about it that I co-work with there, and it's really a privilege. It's a wonderful thing to spend my professional life doing. So I appreciate that.
Let's circle back though to the reason we're talking today, and that is we want to get a little deeper into marijuana. What you mentioned in your introduction about the change in conversation since, say, the 1990s. How would you summarize that change?
That's a great question. I would say there's more information and more confusion, because nothing about marijuana is simple. I think it's one of the most complex issues. We're fairly clear on things around cocaine and heroin and even alcohol, but marijuana is a complex collection. The marijuana plant is actually a complex collection of different compounds that have different effects, both recreationally and medically. And so I think that contributes to a huge amount of confusion when we talk about marijuana, and particularly when we're talking about medical marijuana. So I think the heat has turned down just a little, although I could be wrong about that. And by heat, I mean sort of the emotional clamor. But at the same time, I think there's a lot of people talking past one another, because I think there's not good information out there, especially, again, when we're talking about medical marijuana. And so there tend to be sort of positions that people stake out, but sometimes those positions are not really well informed by the best data, at least that we have at this point in time. And by the way, that's going to be changing constantly. My guess is for the next 20 to 40 years, there's just going to continue to be research digging into the marijuana issue. I mean, I think that's how complex it is.
Recently, I went to a town hall meeting in a small village in my home state of Michigan, where one of the village council members was talking about some pending legislation here in Michigan that would allow communities to authorize licenses for folks to grow or distribute or transport or test medical marijuana. And it was an open town hall, and this gentleman invited people in to make comments. And one of the things that struck me, Allan, although I have to say that I think the crowd was very favorable to him. I think most of the folks who came to the town hall knew where this gentleman stood and were sort of supporting his efforts. But there were some people who had coming from an opposite viewpoint. But it struck me then that the reactions were really twofold, and I think both of them missed the point. There was a group of people there who supported this for this village because of financial reasons. They themselves stood to gain financially by this, or they would make the argument that the village would stand to gain financially by granting these licenses and some of the revenue that would come to the village because of that. And then on the other side, we had folks that were against it But again, I think for the wrong reasons. I think there was a lot of misconception about what these licenses would allow people to do, and from an even broader view, just some misconceptions about what medical marijuana really is. And so when you talked in your introduction about silos, I'm sorry, or you talk about people staking their position, I saw that very clearly. And it seemed to me that both of those things sort of missed the point. There was no real discussion about what medical marijuana is, what it isn't, which is, I think, equally as important. And
I agree.
And how it may benefit people. And I've seen that sort of thing quite a bit over the last several years. People object to these things based on stereotype, or they object to it based on they take a moral stand against it. But it's not an objection based in fact. And I realize that may be a generalization or an oversimplification, but I think in some cases that's true. And I'm wondering if you see that too in your conversations, either professionally or personally.
Well, I do, yes. And it was one of the things I mentioned a moment ago when I was talking about people sort of talking past each other. So I don't. So I have a couple of thoughts here. One is when we talk about medical marijuana, the first thing I want to say is in terms of recreational use of marijuana, and there's not a, depending on, well, there's some variables here, but there's not a whole lot of difference between medical marijuana and recreational marijuana, except for a few strains of marijuana, and I'll get into that in a little bit. But so for recreational marijuana use, I think one of the concerns that many of us who have, particularly who come from the alcohol and drug prevention and treatment side of the field, I think one of the concerns we have is that there's a message out there that marijuana is basically harmless, and that simply isn't true. Not when we're talking about recreational use. The very fact that marijuana may have some medical use suggests that it has the power to alter the body and alter the mind, alter the brain, and all of those carry with them certain risks. So recreational use in particular can carry some risks with it, not the least of which is a dependence syndrome, addiction. And I will tell you that there is no debate left, at least in the research community, on whether or not marijuana can produce dependence. It absolutely can. And we're not talking just about a psychological dependence. We're talking about a type of dependence where people's lives are really disrupted by its use. Relationships are ruined, jobs are lost. Those types of things can happen. And that isn't just because of legal penalties. That is because they stop performing their roles because of their marijuana use. And so there's always a concern about that type of thing, and that doesn't mean that there may not be some medical usefulness for marijuana, but it means that we should approach it the way we do other potentially addictive substances when we're going to use them as medicines. That is, we should approach them cautiously. They should be well researched. They should be monitored in their use, and so on and so forth. I think the other issue that I sort of want to raise here is a language issue. I kind of wish we could get away from the term medical marijuana, because I think it's too imprecise. I think it creates the confusion that we want to clear up. So in the marijuana plant, there are a variety of different compounds. The two of them that are best studied at this point are THC, delta-9 THC, which is a substance that has a few medical benefits, but also is the substance that gets you high and appears to have the addictive potential. The other best studied compound is one called cannabidiol, which I'm just going to call CBD. And CBD is not psychoactive, it won't get you high, and it appears to have a number of potential medical uses. That is, among other things that it can do, it seems to it has sedative properties, sedative hypnotic properties, which means it can help with sleep. It has anti-inflammatory properties. It has antipsychotic properties, so it may be helpful for psychosis and so forth. It may even have some anti-tumoral properties, although I want to say right up front here, there is no research showing that smoking marijuana or even taking cannabidiol per se will treat cancer. It may have some anti-tumoral properties, but that's with a cell in a petri dish. We haven't seen any human evidence yet that it cures cancer. When we're talking about marijuana, I think people have in mind, I think they're mostly thinking about THC. And the marijuana plant can have either higher or lower levels of THC. One of the problems that we have with the recreational marijuana use is that what is desirable in the user is a higher THC content, a higher potency. And because of that, marijuana growers who are growing for that recreational market have tended to push up the THC content, and in doing that, they have pushed down the CBD or cannabidiol content in those plants. And it may be that as we push up the THC content, some of the problems that can cause, not only the dependence syndrome, but potentially psychosis and those types of things. Remember that there was a time when marijuana was classified as a hallucinogen because people could have psychotic effects while they were under the influence. And there is a decent body of evidence suggesting that THC may increase risk for psychosis. And so if we push down the CBD level and push up the THC level in plants, we may be increasing not only the potency for getting high, but the potency for other health problems and other risks that are associated with it. So what I really wish we could start doing when we talk about quote unquote medical marijuana is really talking about the compounds that are in marijuana that might have medical use. And I think that is a part of the issue. Like at your community meeting, you've got people there who are thinking about the THC, and they are concerned about the potential risks from that. And then you've got the other people there who view it as a decent medicine, and why shouldn't our community benefit from the sales of a decent medicine? And so in this is how they end up sort of talking past each other, because on the one hand, there really are risks, especially with THC, and on the other hand, there are some medical uses, both with THC, with cannabidiol, and then probably with some other compounds that you will find in marijuana. So the marijuana plant has over 100 different cannabinoid substances. Very few of them have had any clinical investigation. And I think going forward, we're going to see more and more of that type of investigation happening. So those are sort of the two issues that I felt it was important to say. There's recreational use, and even with medical use, there is some risk that is involved there. And on the other hand, we should really be talking about the particular compounds and the risks of particular compounds. So cannabidiol doesn't appear to be addictive. It seems to have very few side effects from other than what people want from it. And in that sense, it may be a potentially useful medical substance, particularly much more than THC. So in your community meetings, I think you have people who are talking about medical marijuana, and that's been very confused with recreational use of marijuana, because we've not really pulled out and talked about the compounds that we're talking about using and the risks and benefits of those compounds.
I want to come back to that. I have some questions about
Sure.
the issues you've raised, but I want to go back to something you said a few minutes ago. I want to pull that out and maybe have you restate that. You said that there is no longer an argument to be made that marijuana is not addictive or may not lead to dependence. Is that a fair statement?
What I said was that in the research community, there's no longer a debate about that. It's accepted that marijuana and THC in particular can produce a dependence syndrome.
That was I wanted you to highlight that because of arguments I have heard from just people as I talk about this, as I make my way either professionally or personally. I hear that marijuana is not addictive. I hear that frequently, so I wanted you to reiterate that point.
Yes. Well, and a part of that debate, Jim, is around your definition of addiction. So let me talk about that for just a moment, if I may. We have tended in this country, and I think for a large part of the public, this continues to be the issue. We have equated withdrawal with addiction, and marijuana there is a withdrawal syndrome, and as a matter of fact, in the DSM-5, they finally clinically define a withdrawal syndrome, which I was gratified to see. But cannabis withdrawal syndrome, I should say, but it's a relatively mild withdrawal, and as a matter of fact, it may even be attributed to other issues. I'm not sleeping well, or I'm irritable, or that type of thing. But withdrawal is not the actual hallmark of addiction. The hallmark of addiction is when the use of a substance becomes so compulsive that I start neglecting my other life roles and duties, and I start prioritizing its use. Its use becomes compulsive for me. I have to have this now. I can't stop myself from using this. I use more than I intend to use. I wish I could just smoke every now and again, but once I start smoking, I find myself doing it, much more than I want to be doing it. And so that type of that's more the hallmark of addiction, when its use becomes such a compulsion that it begins to interfere with people's lives. And we absolutely see that happening. If you think about the DSM criteria for dependence or a cannabis use disorder, those criteria are largely behavioral. I'm using in times or places that make it hazardous. I'm neglecting roles in my life. I am using, despite knowledge of health problems that I may have, that this may be making worse, and so on. So they are, most of the diagnostic criteria or behavioral criteria that center around sort of an uncontrolled use. Putting into place efforts to try and stop and failing at those efforts and so forth. Those are indicators of addiction. But when the public thinks about this, they tend to think of withdrawal, and then they think about, marijuana may or may not cause withdrawal, and if it does, it's really mild. And so even if it's addictive, and I've heard this actually said, I've seen it on websites and things, even if it is addictive, the addiction is so mild it doesn't really matter. But that's not what our field thinks of as addiction now. It used to be, but we have a different definition of addiction. So in that regard, in the regard that there are people whose use gets out of control, that absolutely is a risk, and it does happen to people. And there is research indicating that the quantity and frequency of use can predict later dependence, a later use disorder, if you will. So when we talk about the addictive potential, we don't mean just withdrawal. We mean really this is interfering with people's lives in a way that they may not even want.
I'm glad you clarified that. I think those were important points. Let me now come back to this idea of the medical cannabis. You mentioned the need to sort of look at this from the perspective of THC as well as the CBDs. When you talked about THC, you mentioned that there may be some medical benefits from THC. Did I hear that correctly? And if so, can you expand on that just a little bit?
Sure. THC has certain sort of well-recognized, potentially medical benefits. It is anti-nausea. If a person is, suffering from nausea, a lot of marijuana users will tell you that if they smoke or vape some marijuana and get the THC, that they feel better. And that isn't just the high; it actually helps the nausea to go away. And I think that's probably, in fact, been the chief sort of medical argument that's often made, is that it appears to be really useful for people who are undergoing cancer therapies, either chemotherapy or radiation therapy. Following their treatments, they're nauseous and possibly throwing up, and THC seems to be able to offset that. So that's one. Another is an appetite stimulant, and this was particularly before we had good treatment for HIV/AIDS. The appetite stimulant for people who had AIDS wasting syndrome and so forth, that this could, the munchies actually are a real thing, and it does stimulate the appetite. And then the other is analgesic. That is, it really helps with pain. So those are probably the three most potent things that THC itself can help with. There is also there is some clinical evidence that THC in combination with cannabidiol, CBD, may reduce painful spasms in people who have multiple sclerosis. And as a matter of fact, there is actually a pharmaceutical preparation of THC and CBD called Sativex that has been approved for that use in other countries, and I believe is the last I heard was in phase 3 trials here in the U.S. But that's for a very specific condition, which is multiple sclerosis. and it's had sort of mixed reviews with some other sort of some other chronic health conditions. But those three, anti-nausea, appetite stimulant, analgesic, which would include the painful spasms, helping to relieve all of those types of things.
Can you help us understand the various delivery methods for either THC or CBDs?
Yeah. So, first of all of the medical authorities who've explored this have said, look, inhaling smoke from burnt plant matter is not a good medical route of administration. So smoking a joint is not a medically desirable route of administration. One of the reasons there is a real interest in some of the vaping, the vape pens and the vaporizers and those types of things, is that you can heat the plant material to a point where it releases some of those cannabinoid substances in a vapor that can be inhaled, but you don't get the problematic smoke that you get from burning the plant. So vaping is another route of administration, and those are probably the two chief ones. They are also looking at they're also now the oils. So cannabidiol oil that can be put in drops under the tongue and just mostly absorbed, through the mucous membranes of the mouth. And that bypasses it having to go into the stomach, where some of it is going to be broken down and metabolized. So by absorbing it in the mouth through drops or through an inhaler spray, where it goes into the lungs and out into the bloodstream, all of those are things that are being investigated. One of the problems with the inhalers, although there is work that is going on this, all of the cannabinoid substances are fat-loving. They want to be in fats or oils, and you obviously don't want to be inhaling oils into your lungs. And so the drops, the oil drops under the tongue, they're looking for ways to infuse the cannabinoids into something other than oily substances for inhalation purposes. And there's research, I think, going on that route of administration. But those are probably the main routes of administration. Let me say a word about the vaping in particular. So for those of us who work, again, in the field related to, dependence and addiction and the public health concerns, one of the issues with vaping is that you can get a much more powerful dose. So the butane hash oil has very high levels of THC in it. You vaporize that, and you can get an enormous amount of THC essentially in a single breath, and much more than you would get from smoking a joint. And that has two potential problems to it. One is that the person can get more impaired than perhaps they intended to get. And the other is that anytime you increase the potency of a dose of a substance that has an addictive potential, you probably move the needle toward addiction more rapidly with those higher potent doses being taken over and over again. So vaping, vaporizing certainly has its benefits in terms of bypassing the smoke, but it may increase the risk, particularly for impairment and addiction.
What can you tell us about edibles?
I'm sorry, I did not think of edibles. I totally missed that. So on the edibles, often have significant amount of THC in them. When they go into the stomach, they get broken down and go out into the bloodstream, and they do a first pass metabolism through the liver. And the first thing that the liver does is that it turns the THC into its first metabolite, which is hydroxy THC. There's a long chemical name for it, but we'll just call it hydroxy THC. And hydroxy THC is at least as potent in terms of the euphoric high. It's at least as potent as THC itself. So it will cause an equal or even greater amount of impairment. But in terms of its medical use, the onset of the effects is delayed. So, for example, we've known about the nausea issue, the anti-nausea properties of THC for a long time, and we've had a chemical preparation of THC, dronabinol, or the brand name Marinol. But people who are dealing with nausea don't really want to wait anywhere from a half an hour to 2 hours for an effect for taking an oral preparation of THC when they can get relief in a matter of minutes from inhaling THC. So so with the edibles, once again, there's sort of they're easier to take. Some people don't want to smoke or inhale anything. They're easier to take. We all know how to eat. And the onset of the effects is longer. This increases the risk that a person will overdose. And as a matter of fact, one of the first fatalities that they had in the state of Colorado was with an edible, where a young college student who had no experience with marijuana came to Colorado on a break. He got a marijuana cookie, is my understanding. The dose was 1/6 of that cookie, which he took. He waited a half an hour. He felt no effects. So he ate the rest of the cookie. And then not long after that, he had a psychotic break and became more and more erratic until finally he leaped off the balcony of the hotel room that he was staying in and died. So there's this potential for overdose with the edible route, unless people know that they're just going to have to wait on the effect, and then the effect is harder to adjust because whatever you put in, there it is. So maybe it's not what you want as much, or maybe it's too much.
This may be an unfair question, but I'm going to ask it anyway. We've talked about the research community that you're a part of. We've talked about some of the public misconception or lack of understanding of these things. What is the view generally of the medical community? Are you seeing a shift in the view of medical providers in terms of at least looking at cannabis as a medical option? Is there still some resistance to that idea? I realize it's an unfair question because we can't lump everybody in the medical community into one answer, but I thought maybe you can tell us a little bit about what you're seeing there and what your experience is.
Yeah, and so I can let me be clear. I don't have a huge amount of interaction with the medical community per se. I have some. So what I'm hearing, though, from the medical community is not a whole lot different from sort of what we're hearing from the public. And, it's important to understand that doctors are just people, and they hear what they hear and think what they think as well. So I think what I hear from the medical community sometimes is some frustration that they, on the one hand, They feel like there may be some medical benefit here, but it's all very undefined, and it's hard to know what to say. If they have patients who come in and say, I'm using this, I'm taking this CBD oil, or I'm smoking because this helps me with my nausea, or, I think they oftentimes don't know what to say about that from a medical research standpoint. And let me just say that the medical research is thinner than it needs to be. We need good clinical trials with different cannabinoid compounds from the marijuana plant. Preferably placebo, double-blind controlled studies that really tell us, is this helping, is it hurting, is it benign, is it doing nothing at all? And that kind of research is only just now starting to happen, and it's difficult even to do that kind of research because of government restrictions on research and research funding, which is a real frustration in the medical research community. And that's what I hear from that community. So I think the doctors are operating sort of out of the best information that they think they have, based on what they know or what they think about it. They have been, advising patients. But I think what I hear is their wish is they wish they had clearer, better information than they're getting on the subject.
You mentioned some of the barriers to this research. Now my understanding, limited as it is that part of the barrier is that marijuana is still classified as a Schedule I drug.
Correct.
Maybe talk a little bit about what that means. What does it mean to be a Schedule I drug?
Well, under the federal guidelines, if a substance is a Schedule I drug, then they consider it a drug with high abuse potential and little to no medical benefit. So that's sort of the definition. So, for instance, cocaine is a Schedule II drug, which means it has a high abuse potential, but we do recognize some medical use for it. It's used, for instance, in veterinary medicine. It can numb tissue. If you sprinkle cocaine on tissue, it can numb it, and so forth. So there is some recognized medical use actually for cocaine. So that makes it a Schedule II as opposed to a Schedule I. So there's sort of an ongoing petitioning of the DEA, who are the ones who determine that scheduling. There's sort of an ongoing petitioning of the DEA to reschedule marijuana. And my thinking on that is that I wish they would begin asking for a rescheduling of the various compounds and rescheduling of the compounds perhaps in concert with each other, so that we really can do better medical exploration than we're doing now. But right now, because it's a Schedule I drug, that means that funding is limited. It's hard to get funding to do the research, and if you want to get, and if you're going to do that research, you have to get your marijuana from the federal government. And that involves, I've heard people in that community attempting to do that research say this requires massive amounts of paperwork and, protocols that you have to have in your lab and all kinds of things that are pretty burdensome. If instead it were rescheduled to, something put in a different place on the drug schedule.
Just for context, Allan, what are some other Schedule I drugs?
I don't know. Heroin, I think, in the U.S., heroin is considered a Schedule I drug.
Okay, so that we get some sense of how marijuana is viewed in relation to heroin and that, as you mentioned, cocaine, which is a Schedule II drug. That, right. If I'm correct here, that I think there was some thought that earlier in this year, in 2017, that there might have been some movement by the DEA, but that did not happen. Is that correct?
That's my understanding. I think it was in. Yes, there was a consideration. The DEA did take up, the issue of potentially rescheduling marijuana, and in the end, and I forget whether that ruling came. I think that ruling came maybe in early summer, but I could be wrong about that. That they would not change the schedule on it. So my guess is that will just continue to happen until the DEA changes its mind. Because as I said, there are compounds in marijuana I think really do have we should have some medical investigations on some of those compounds in marijuana. I think there's no question about that. And I wish we could, ease the restraints a little and facilitate that research.
Are you suggesting that some of these compounds could be classified individually?
Yes, and I wish they would be, because when we talk about, here's the question: is marijuana a medicine? Well, marijuana is a medicine in the same way that you might, use white willow bark for a headache. You might make a tea or chew some white willow bark in order to treat a headache because it has an aspirin-like compound in it. Well, we've purified that compound, and now if I have a headache, I don't have to chew on willow bark. I can take an aspirin. And what I wish we would do, and what I think we could do, is begin really investigating the individual compounds and those in combination with each other for their potential medical properties. And we could perhaps schedule them. So, perhaps CBD goes to a higher, less restrictive drug schedule than THC does. If they are being done, if they're being taken independently of one another. And there are plants out there that have very high CBD levels and very low THC levels. I don't know if you recall, some time back, Sanjay Gupta did a show about marijuana, and he highlighted a young girl in Colorado who had Dravet syndrome, and she got CBD oil. Unfortunately, he just kept referring to marijuana, and people didn't take from that this, 3-year-old child wasn't smoking a joint. Her parents were using an extract, a pure CBD oil, essentially pure CBD oil, and putting that in drops in her, I think in her food or under her tongue, I'm not sure which. And she had, rather dramatic improvements in her seizure disorder. So I think we could look at rescheduling those independently of one another. And my whole problem with the referendums and the legislative processes that we're doing on medical marijuana is that it's short-circuiting our drug approval process. We have an established drug approval process in this country, and it's sort of out of a sense of frustration with the government not allowing the legitimate research to be done, and a push from advocates who saying, this plant really helps me, that we've pushed the public's opinion on this, and we've pushed legislative opinion on this to say, let's just make it available apart from our whole drug approval process. And so now we have this drug out there in medical marijuana states that is available generally to anybody who wants to go get it if they can persuade a doctor that they have some need, some condition that marijuana might help. And too often that's being done without any medical monitoring, although in some of the states now they've started requiring more medical monitoring of that. But in doing that, here's what we have not identified. We have not really identified who shouldn't be getting this medication. People with a family history of psychosis disorders probably should not be taking marijuana, in at least THC, in any form. CBD is a different issue. We have people who should not be getting medical marijuana, quote unquote. And we don't know how it interacts with other drugs that people are taking. Most of what we know about marijuana's effects on the human body come from its recreational use in younger, healthier adults. And we don't know what happens with that when we start going to other age groups and people who are already have their health compromised with other health conditions. So we've just sort of bypassed this whole system that we have for investigating drugs. We're just now sort of putting it out there for the public to use. And I think from a public health perspective, that concerns me.
This is going to be fascinating to follow over the next 5, 10, 20 years, don't you think?
Oh, it absolutely is. I think we are on the threshold of some really decent new medicines. Cannabidiol, and I always have to do this a little with some caution. Cannabidiol looks pretty darn wonderful. However, having said that, it seems to have all these beneficial health benefits without getting you high, without the addictive potential. I say all of that, and at the same time, over and over again in our nation's history, we have had drugs introduced that were supposed to be the new next wonder drug, and they did do what they were supposed to do, but as more and more people used them in the public, they turned out to have problems that we didn't identify earlier on. So, but I do think you're right. It's going to be fascinating, and I think as we look into these other compounds that are in there, cannabigerol and some others that are out there, that we are going to, I think we're on the threshold of a whole new class of medications, cannabinoid medications. And I wish we could just get on with our clinical investigations of that so that we know what does and doesn't work and for whom it does not work. But yeah, it's going to be interesting to watch.
You have your work cut out for you.
We all do.
Let's. I just want to shift gears just a little bit here. Okay. What have we learned from places like Colorado and Oregon and other places where there is legal recreational marijuana and has been for now a period of time? What have we learned?
Yeah.
Both good and bad.
Yeah. I think, I should have anticipated that question, and I wish I had looked at this some more. So I'm now going to talk off the top of my head just a little bit. I think one of the things that we've learned, one of the concerns that people have had is that it will increase adolescent use. And I'm not sure if we've really seen that happen, but here's what we have seen. So that's maybe the good thing. We haven't seen a huge increase in the numbers of people who are using it. But here's the flip side that you rarely hear about. Among those who are using it, they're using it more and more often, and that's not good when we're talking about THC. I think there's increased risk in the using population. The using population grew for a while. For more longer-term effects, even though it's been a few years since we had the legalization there, I'm not sure that we have enough history yet to know, what the long-term benefits are. My understanding is, and boy, I'm really talking off the top of my head here now, my understanding is that there has been an uptick in people meeting criteria for cannabis dependence or cannabis use disorder. At least in Colorado, I have not seen data on Washington on that. And of course, we have other states who are coming on with legal use. Alaska's already there. I think Maine's begins maybe at the first of this coming year. Recreational use will be permitted there, and so forth. So I think we're still sort of early in that. But I wish I had really looked at some data on that, but I confess I'm underinformed on that.
One of the things that I've seen is echoes what you've seen, and that is that there may not be a significant increase of marijuana use by adolescents in these states, but of concern is the fact that the perception of risk has gone down.
Correct. And so among those who are using it, the use, the quantity of use and the quantity and frequency of use seems to have increased. And quantity and frequency with THC is predictive of future cannabis use disorder. So that is concerning.
It's going to be interesting to watch that as well. Here in my home state of Michigan, there are efforts to push for legal recreational marijuana. I don't, the train has sort of left the station on this, and I think we are going to see more places move forward with it. We've seen national studies that tell us that over 50% of the population is in favor of it.
Right.
So the momentum going forward. There's been. And again, I tend to say this, and I don't know if this is really true, but in my lifetime, now as a middle-aged man, there have been really some of these issues pop up from time to time, and they seem to move with great speed. I mean, if we looked at this issue 10 years ago, there wasn't the same kind of momentum, and then just recently there's been this great momentum. I think I saw the same thing. We saw the same thing maybe several years ago with marriage equality, where it just picked up momentum very quickly. And whether you are for or against these things, the speed at which the conversation changes is remarkable to me, and that's part of my interest in marijuana, not only from just professional interest in this, but also just looking at it from a 35,000 feet perspective and saying, wow, look how fast this conversation is changing. It's remarkable.
Yeah. It is. And let me give a little expression to my cynical side for just a moment. Marijuana is becoming a billion-dollar industry, and there are multi-billion-dollar industry in all likelihood. And there are moneyed interests out there who have a vested interest in changing public perception. So that's part of what's driving it. And also, I think a part of what's driving it is that you do have people who say, look, I have this medical condition, and when I use marijuana, when I do this or that, then I feel better, I function better, I do better in my life. And that's hard to argue with. I think the American public tend to be sort of fair-minded and compassionate, especially when it comes to people who are ill. And so, we have sort of said as a culture now, well, we need to help these people. And I think I certainly agree with that. We do need to help these people. I just wish we would go about it in a more research-based way and allow for compassionate use, sort of on the fly as we are now. But also let's dig in and really find out, is this as good a medicine as we have? Are there other things that do as well or even better? And at the same time, are there real benefits here, and can we get this to people in a more measured, more purified, more medically monitored form that reduces the risks and increases the benefits, which, I think would be what everyone wants. The problem is, as you mentioned, the perception of risk has fallen, and so people are just sort of full steam ahead on let's get the benefits, both pharmacological and economic benefits, without, I think, an awareness of the risks that are there.
Well, that's a great summary, Allan. I feel like we've barely scratched the surface here, but if people who listen to this want to learn more, where would you direct them?
Boy, that's a great question, and it's a question that I get fairly often, and I honestly don't know what to say to people about that. Right now the information that is out there tends to be sort of, in schools of this is great and this or this is terrible, and getting balanced information is really tough. So what I would suggest is that, when you read media reports about marijuana, we should be asking which compound are they talking about, or are they talking about just the plant, the whole plant? And then the other question, that we should keep in mind is, well, what are the risks associated with that? But where to go to get sort of a summary or, a deeper look at what we're saying here, that's hard, actually. I don't know of anywhere. And unless you're just willing to dig into the research literature yourself, because that's where it is now.
If people had questions for you, is there a way that they can reach you with questions?
Yeah, they can email me at it's Allan, ALLAN .Barger, BARGER at primeforlife.org, PRIMEFORLIFE, all spelled out, primeforlife.org.
This has been fascinating for me. I want to. We've kept you quite a long time. I want to thank you for your time. You've given us just a great deal of information, and I think you've gone a long way toward educating people about what the term medical marijuana really means, and so I'm very happy about that. And I want to thank you again for your time.
Well, thank you. I appreciate the opportunity to say it. I think it's a really important issue, and I appreciate hopefully adding some light to the. I've always said my goal is to turn down the heat and turn up the light in our discussions on this. So thank you very much.
Yeah, Allan, I look forward to seeing you down the road.
Thanks. You too, Jim.
Thanks for listening to this episode of the ADE Spotlight Podcast. If you would like to be a guest on one of our podcasts, or if you have an idea for a topic you'd like us to cover, please feel free to drop us a line. We'd love to hear your suggestions. If you haven't done so already, I encourage you to check out ADE Solutions, a new website from ADE. There you will find a variety of quizzes and assessments covering a whole range of behavioral health related topics, including substance use, gambling, mental health disorders, eating disorders, and the like. If you have concerns about yourself or a loved one in these areas, please access the website and check out the assessments. Or if you simply want to expand your knowledge on these topics, on the education tab on that website, we have a variety of quizzes as well as other podcasts similar to the one that you just listened to. You can find that at www.ade.solutions, or you can link to it from our corporate website, www.adeincorp.com.